Dr. Vinod Kumar Singh sir. They have agreed to just blessed us since these two topics, common cardiac topics, are very common in periphery, and we are often face problem. So I have thought that this topic would be very relevant for us. So first topic is uh, inotropes and vasopressors in ICU. So this is very common topic, and often we come across these problems. And a speaker is none other than Dr. Pradeep Kumar Bhattacharya. He's himself at present he's President-elect National ICCM. He's MD, ACME, FICCM, FCCM, FCCM, and head of the Department of Critical Care Medicine, Rajendra Institute of Medical Sciences, Ranchi. And now I invite Dr. Pradeep Kumar Bhattacharya, sir, to.
Shall I start?
Aye.
So, Bolo, JP, you are saying something.
Yeah. Good evening to both our speakers. They are well-known figure in India, across India. So, before starting, I would like to also introduce Dr. Vinod Kumar sir, Vinod Kumar Singh sir. He is from Chhapra. I feel that many of are not aware about that. Sir is from Chhapra, and sir is out right now. He is senior consultant in Department of Critical Care Medicine in Gangaram Hospital, New Delhi. So now I feel that we should proceed with them, because we are waiting since long time to start this program, and on the banner of ISCCM Chhapra. So in coming time, definitely we would like to start our offline CME. And first I would like to say, Dr. Pradeep Kumar Bhattacharya sir. Sir, please proceed. Yeah.
Thank you, Dr. Jayaprakash, and thank you, Dr. Rajiv Ranjan. It is my privilege that I'm invited for this online webinar on critical care, which is being organized under the banner of Chhapra City branch, and which is about to open. And my all good wishes to them, so that they can open this branch at the earliest. And for that, for this meeting, I must thank Dr. Rajiv Ranjan, Dr. Rakesh Kumar, Dr. Nishu, and Dr. Jayaprakash for starting the process. But ultimately, you have to do a physical meeting to start your city branch. And as all of you know, that prerequisite for that is that you should have at least 10 members who are registered with ISCCM. And then you do a formal meeting. You can call one of the executive committee members from ISCCM National. You do a physical meeting in your city, and then you do a formal inauguration of that, and the same meeting you can designate who will be the chairman, who will be the secretary, and who will be the treasurer, along with 4 other executive committee members. So in that way you can format your city branch and you can start, and gradually you can go on adding more and more members, and that is how it should happen. And I presume that very soon it will be started in Chhapra, and my all good wishes to the team of Chhapra to take this initiative. I met Dr. Rajiv Ranjan, I think, a couple of months back. At that time, I found that he is a highly enthusiastic person, and he he was very keen to start this critical care chapter in a city, and now he's almost done. Only thing is that he needs to do a physical meeting before he goes for a final city branch certification from ISSM National. So with that, I think because this is a CME program, and without wasting time, much more time, and I must congratulate the entire team and thank JP Jayaprakash for taking this initiative uh, to start this CME, at least in the form of eCME. We can connect many other city branches where it is because of paucity of time we cannot reach there, but obviously we can always connect with the small cities, and we can do webinars like this, and it will help not only the practitioners but also all those students who are working in different medical colleges which are there, and also different kind of setups on their cities. So with that, I start my presentation. I hope my slide is visible to everyone.
Yes, yes, it is visible.
Is it visible? Okay.
Yeah.
Yeah. It's visible, sir.
Go to the
It's
slideshow,
visible, sir.
Pradeep.
We cannot. From beginning. Now is it okay?
Yeah, now it is fine.
Okay, sir.
So inotropes and vasopressors in critical care. Vasopressors, all we know, inotropes and vasopressors, they are classified according to their way of acting on action mechanism, how they work on our body, whether it is adrenergic system or a non-adrenergic system. So it may be either in the form of adrenergic action or in the form of non-adrenergic actions. So all those agents which has got an adrenergic actions are norepinephrine, phenylephrine, epinephrine, dopamine, dobutamine, and isobutanol. Whereas all those agents which have got non-adrenergic actions, they include angiotensin 2, which is a new molecule, the nitric oxide inhibitors, then vasopressin, milrinone, levosimendan. So these are the agents which are basically agents which acts through different mechanisms. I think we can ask everyone to mute their mics because some noise is coming, abnormal noise is coming. It is
From my side, I will
mute everyone other than speaker. Okay. So many drugs have got vasopressor as well as inotropic effects. We'll be see one by one how it. So first of all, let us try to understand the potential positive and negative hemodynamic effects of these vasopressors in critical ill patients. So the most important thing is the cardiac output, and second most important thing is the peripheral perfusion. So what is the action of vasopressor? The vasopressors, they actually try to constrict the vessels at peripheral level so that it increases the microcirculation by increasing the perfusion pressure. And also by virtue of that, it increases the blood flow and decreases the capillary permeability, which happens in many type of shaft. And that is the most deteriorating effect which can happen because of shock. So microvasculatory leakage, if you can stop, then definitely the things becomes better. On the other hand, if we look at in the form of central action in the heart, they increases the coronary perfusion pressure. They increases the inotropic effect at the heart by beta agonist action and increases the venous return also. But they have little or some detrimental effects, so which we have to accept while you are using, because here more for the benefits rather than less for the harmful effects. They, on the other hand, they causes some amount of coronary vasoconstriction, increase pulmonary circulatory vascular resistance, that is pulmonary vascular resistance, and also it increases cardiac afterload. So when you are using vasopressin or norepinephrine, this is systemic vascular resistance is increases, And that may have some benefit or some harm that we have to accept. And along with that, there may be some decrease in regional blood flow, as well as sometimes oxygen demand of the heart is also increased in these patients. So if we say to start with different kinds of shock, how these inotropes and vasopressors are used, because I'm not going to the hardcore pharmacology, because that is not relevant from the point of critical care, and this is a short discussion. I think I must tell you about the important facts as far as critical care is concerned, rather than going to the hardcore pharmacology. So let us see what are the different types of shock which we see, and how these inotropes and vasopressors are used in this different kind of shock. So first is hypovolemic shock. So what happens in hypovolemic shock? There is a huge amount of volume which is lost from the intravascular space. So initially what happens, there is a compensatory mechanism from the sympathetic system, and which promotes vasoconstriction, by virtue of which there is a arterial and venous vasoconstriction, and finally the hemodynamics are maintained. But when this mechanism become overwhelmed, then the sympathetic system is exhausted, and this autoregulatory mechanism fails, and there is a subsequent peripheral vascular resistance goes off, and that we called as a state of vasoplasia, or a vascular hypoperfusion state is developed, where there is complete vasodilatory state and there is no action of inotrope. The autoregulatory mechanism doesn't work, and that happens because of excessive secretion of nitric oxide. And here, this is the point actually where we need to intervene. So first drug which is used for this kind of vasodilatory state is the norepinephrine, and norepinephrine is the first line agent, because it has got a good action as far as, because as I said, it is a state of vasoplasia. Because of its sympathomimetic properties and a stimulant action, it causes a good vasoconstriction. And along with that, inotropic support in the form of dobutamine or epinephrine should be administered, where we see that because of hypoperfusion, some kind of myocardial dysfunction has also occurred, which could be suspected if the patient does not respond to fluid resuscitation and norepinephrine administration. So in that situation, you have to use inotropic support in the form of dobutamine or epinephrine. But it should be noted that vasopressor should be administered along with adequate fluid, because norepinephrine alone could lead to a detrimental effects. So the volume status of the patient has to be adequate before we feel that yes, now we need to start an inotropic or vasopressor agent, because otherwise there may be some detrimental effect which we have to face because of this vasopressor agents. Now the second one is very easy as far as hypovolemic shock is concerned. But when we talk of neurogenic shock, the things becomes little tricky, where and how we need to use this inotrope and vasopressor. Here, what happens, the hemodynamic profile changes because of the loss of supraspinal sympathetic excitatory input to the sympathetic preganglionic neurons. And that happens because of the damage to the spinal cord. And this reflex is very crucial for maintaining the blood pressure. So vasopressor therapy, that depends upon the level of injury with the patient's hemodynamic profile along with. So what happens if the damage has happened in the cervical region or up to T6 level, then we have to understand that heart is mainly supplied by the dermatomes from the T1 to T4. So anything which is happening above T6 level, you need to add some vasopressor agent. So there is a demand of vasopressor agent with both inotrope, which has got both inotropic and vasoconstrictive properties to support both the vessel tone and cardiac contractility. So reason being that, as I said, that sympathetic innervation of the heart, it originates from T1 to T4. And dopamine and norepinephrine are the agents which are very specific and can be used at this level. But if there is an injury at lower thoracic or lumbar level, it warrants the need of a specific vasoconstrictors. Like we use phenylephrine. If it is happening below T6, then the drug of choice is phenylephrine, which acts only on alpha-1 receptors, because it will be a complete vasodilatation without any effect on the heart. So that is why our drug of choice will be phenylephrine. Epinephrine is not widely used because it also has gotten a beta-1 adrenergic effect, which can affect the heart and can give rise to arrhythmias. So I think now it is clear, if there is any injury above T6, what we need to use inotropic as well as vasopressor agent. But if the injury is below T6 level, then the drug of choice will be phenylephrine. Okay. Now come to the most important one, that is the cardiogenic shock. Now, first of all, what is the definition of cardiogenic shock? When we say that systolic blood pressure is less than 90 for more than 30 minutes in absence of inotropic or vasopressor support, or a reduction of cardiac index of less than 1.8 liters per minute per meter square without support, and or less than 2.2 liters per minute per meter square with support, and elevated left ventricular filling pressure, that is pulmonary capillary wedge pressure of more than 18 millimeters of mercury, then we call it as a cardiogenic shock. So in general, what we say, there is a loss of more than 40% of the functional myocardium, then the patient will develop a state of cardiogenic shock. Now, why we administer vasopressor? Vasopressors in cardiogenic shock are administered to raise the blood pressure and to restore the end organ perfusion, because if there is no perfusion, the organ injury will start. And another thing is that inotropes are used as they increase the myocardial contractility and thereby increasing the cardiac output. So we need both the things, both basically increase the cardiac output as well as vasoconstriction. Often what happens that these kind of agents, it increases the heart rate, and subsequently there is an increase in the myocardial oxygen demands, which again worsen the patient condition. So that we have to keep in mind, and we have to make a balance that how we are going to use a combination of vasopressor and inotrope in these patients. So along with the positive inotropic property, these drugs manifest peripheral vasoconstrictive and vasodilatory effects. And these vasoconstrictive and vasodilatory effects again have got some therapeutic advantages as well as therapeutic disadvantages. Now look at the effect of dobutamine, because we know that this is one of the best cardiac output drug, which increases the cardiac output in a state of cardiac dysfunction. But the disadvantage is that it increases the heart rate. And the advantage is that it increases the stroke volume, cardiac output with a concomitant decrease in left ventricular filling pressure. So as the patient goes into the dilatory state, obviously the left ventricular filling pressure will be low and a modest decrease in blood pressure and SVR. So decreases both, but on the other hand, it increases the cardiac output. Thus, it seems to be an ideal inotropic agent, because as such, in a dilatory state, the load on the heart will be reduced. That is why it is the ideal agent for cardiogenic shock. The dose is 2 to 15 microgram per kg per minute and does not require any renal adjustment. That is the beauty of this drug. Then what about epinephrine? We call it as an adrenaline. Epinephrine increases the stroke volume and cardiac output, and it decreases the systemic vascular resistance by stimulating beta-2 receptor in the skeletal swing. It also increases the pulmonary vascular resistance and right ventricular afterload, and that is the demerit of this drug, because it causes severe pulmonary vasoconstriction and right ventricular afterload, and that is why it has not been found to be a very good drug for cardiogenic shock. So nowadays it is rarely used in acute decompensated heart failure, because it increases the myocardial oxygen demand and that leads to ischemia. Okay. Now, another important drug, as I said, norepinephrine, it increases the systemic blood pressure, pulse pressure, peripheral vascular resistance, and stroke volume. So in response to norepinephrine therapy, the cardiac output usually does not change, or sometimes it has been found that cardiac output decreases. And there is a compensatory vagal reflex, and that's heart rate. Dr. Jayaprakash, can you check the sound which is coming from?
Done, sir, done.
Norepinephrine is widely used as the first line agent for increasing the blood pressure. As I said, that it has got a very good vasoconstrictive property by virtue of which it increases the peripheral perfusion. And because of the bad effects, as I described, of dopamine, it is now considered as the preferred agent. And the recommended dose is 0.01 to 0.03 milligram per kg per minute, and maximum dose, maximum suggested dose is 0.1 milligram per kg per minute. So you can go up to a much higher level. Now, the old and well-tested drug, which we used to use long time back, and now also we use it in certain situations, the dopamine. Dopamine is, as it is described, and we are reading from our early MBBS period, that there is a dose-dependent action of this drug. At low doses, it causes vasodilatation, and it increases the splanchnic and renal artery circulation. And that is how it, once upon a time, it was thought that it is one of the drugs which is very useful for renal failure. Nowadays, almost that indication has gone, almost is extinct, and we are not at all using this drug for renal vasodilatation. But at higher doses, it promotes peripheral arterial and venous vasoconstriction. And in patients with cardiogenic shock, dopamine increases again similarly, like dobutamine, heart rate, cardiac output, stroke volume, and left ventricular end diastolic filling pressure, whereas it reduces the SVR. So almost similar like that of dobutamine. But there was a trial which was published in New England Journal of Medicine from when this craze of this drug has gone down, the SOAP-2 trial. An investigator which suggested that the patients with cardiogenic shock who were treated with dopamine had a higher 28-day mortality as compared to those treated with norepinephrine. And from that point of time, the craze of this drug has gone down as far as cardiogenic shock is concerned. So now this is a non-adrenergic drug, that is milrinone. Milrinone, what it is a phosphodiesterase inhibitor that prevents the degradation of cyclic adenosine monophosphate, and it prevents it in patients with heart failure. Milrinone, again, like dobutamine, dopamine, it increases the heart rate, stroke volume, and cardiac output. And it also decreases the mean arterial pressure, systemic vascular resistance, and left ventricular filling pressure. So again, the actions are almost same like dopamine and dobutamine, but it has been found that although it improves the hemodynamics, but there is a concern that it causes new onset atrial fibrillation and flutter and sustained hypotension. So it has got a almost a prolonged vasodilatory effect when the drug is used, and this is the rationale why milrinone is indicated only in those patients who are having refractory cardiogenic shock. It is not a very frequently kind of used drug, but obviously in cardiac surgery patients who are actually refractory, they are cardiogenic shock, there I have seen, and I also have used this drug many a times. The recommended dose is 0.35 to 0.75 microgram. Now, another important non-adrenergic drug is levosimendan, which is a calcium sensitizing agent and which exerts a positive inotropy effect on the heart by increasing cardiac contractile apparatus sensitivity to calcium, which is sensitive to calcium. So it is a calcium-dependent molecule. And if we look at the trials which has happened, which was the SURVIVE trial, which was published in JAMA in randomized controlled trial, which compared its efficacy with the dobutamine, and they studied in 1,327 patients, and they revealed that levosimendan did not reduce all-cause mortality compared to dobutamine. And on the other side, it has manifested as a more peripheral vasodilating effects as compared to dobutamine. So obviously, prolonged hypotension may be another a problem which could be expected from this drug, and that is why again it has not become so popular like dobutamine. So therefore, levosimendan's role in cardiogenic shock is still not clear, but we have seen studies where it has been used in patients with right ventricular failure, with some studies suggested and given good outcome. But I think a strong recommendation as far as this molecule is yet to be seen. Now, the most important shock which we see in ICU is the septic shock. And we all know that the use of norepinephrine in the first 2 hours of resuscitation could restrict the amount of fluid administration in long-term management, which may lead to adverse outcomes. So this is one drug which is very, very useful, norepinephrine, as far as septic shock is concerned. And nowadays, the concept says that simultaneously, along with fluid resuscitation, you start this drug, and the patients were both are started simultaneously, it has been found and outcomes have been better. So it is better to take another important thing, that is the diastolic arterial pressure. So in those patients who have got a low diastolic arterial blood pressure, the early initiation of norepinephrine has been found to be much more beneficial as compared to those who are having a systolic hypotension. So diastolic hypotension patients benefits better as compared to systolic hypotensive patients. So, as suggested by surviving sepsis guideline, norepinephrine is the first vasopressor that should be administered in cases of septic shock. And the mean arterial pressure, which they have said, is that more than 65 millimeters of mercury, that is to be maintained. And it has been found that if we maintain at this, it increases the tissue oxygen saturation, and that is how it helps in peripheral perfusion and recovery of tissue hypoxia. So often what happens in sepsis in patients, suppose there is a patient who already was hypertensive and his homeostatic system or hemostatic hemodynamics are different as compared to a patient who is a normotensive. So that is why this concept that is called dissociation between macrocirculation and microcirculation, this concept was developed. So what happens, those patients who are hypertensive, and if they goes into septic shock, and that time the hemodynamic targets are absolutely different. So baseline targets in those patients are different, and that is why you need to manage those patients in a different way. So norepinephrine is the vasopressor of choice, as I said, but dopamine can be considered as an alternative solution only in highly selected patients with low risk of arrhythmia. As I said, this drug causes high level of arrhythmia and absolute, or if you see that patient has got absolute bradycardia. So at that time, dopamine may be helpful. Then epinephrine is one of those drugs which actually have the properties of both norepinephrine and dopamine. So if you combine norepinephrine dopamine characters, it will be the character of epinephrine. But the drawback is that epinephrine causes an increase in lactate level, and also it causes peripheral tissue ischemia, and that is why it has been found to be dangerous when it is used in septic shock. So epinephrine is considered as an adjunct, where you see that norepinephrine you are using at a very, very high dose. So to recruit or to reduce the dose of norepinephrine, you can add a little bit of adrenaline norepinephrine to get the advantage of perfusion, that is perfusion pressure, to maintain the perfusion pressure at the tissue level. Now, vasopressin is another endogenous peptide hormone that is released by neurohypophysis, as we know, that posterior pituitary, and it promotes non-adrenergic vasoconstriction. And it has, if this drug is used in earlier part of the sepsis, it has been found to be very, very helpful. But again, because in the early phase of sepsis, there is a endogenous vasopressin stores are depleted, and that is why it has been found to be useful if it is given in the earlier phase of sepsis. But again, as it has got a catecholamine sparing effect, so it can always be combined with norepinephrine when we see that the norepinephrine dose is going beyond an expected limit. The myocardial dysfunction is common fact in sepsis. And again, if you find that there is a component of myocardial dysfunction, then you must think of dobutamine. And that is the first line of choice in patients who are in sepsis, and those who have developed myocardial dysfunction. Now, milrinone is recommended only in patients who have got chronically beta blocked or who are having chronic heart failure whose adrenergic receptors are desensitized. So that is the point where actually you see that adrenergic drugs are not going to act. There you can use milrinone. And levosimendan is not currently used in septic shock. And here the further investigations may shed a light upon the use of agents. Where to use this drug is yet to be identified in patients with septic shock. Now, anaphylactic shock. We all know that it happens many a times while we manage our patients in ICU, and this is one drug which actually is time tested is adrenaline. Because of its alpha-1 agonistic events, it prevents the airway edema, it also prevents hypotension, it improves the blood pressure, and because of its beta-2 agonist action, it induces bronchodilation. So all airway catastrophes can be prevented with the use of this drug, and that is why it has been the only indicated drug which should be given intramuscularly, 0.5 milligram rather than 1 milligram. 0.5 milligram if you give immediately as the patient develops anaphylactic shock, it has been found to be useful, very, very useful. And only relative contraindication in elderly patients who are having a beta blocked heart, it should be avoided. Now, what we are looking at future. In future, what is going to happen is early multimodal vasopressor therapy. Now, in future, we are going to be identified by our genetic polymorphism and the circulatory polypeptides which are there in our blood. And depending upon that, the type of vasopressor, whether I'll be responsive to norepinephrine, or whether I'll be responsive to angiotensin, or whether I'll be responsive to vasopressin, it will totally depend upon the genetic profile of the person as well as circulating peptides. And that thing is coming. I think in future, we are going to get this thing. And in another 25 years, probably all these things will be established. So currently, what we can see that amongst all, although I have discussed that non-adrenergic agents, they have got very few indications as far as shock is concerned, but other than vasopressin. But when we talk about this adrenergic agent, where it should be used, like adrenaline, it has found to be useful in cardiogenic, septic, anaphylactic, and cardiac arrest situation. Noradrenaline is useful in septic, cardiogenic as vasodilatory shock. Dopamine is useful in cardiogenic, septic, and septic shock. And dobutamine, whereas there is a myocardial dysfunction and low cardiac output state, it has been found to be a very, very useful drug. The respective doses are given. And if you look at the major side effects, again, are in the form of arrhythmias and hypertension. So these are the two major side effects which we expect of all these adrenergic drugs which can happen. So I think to conclude, there are a few important points you must remember. First of all, that you must set a goal of mean or diastolic pressure. Don't look at the systolic pressure. Or if you have a monitor, you look at the cardiac output. That is the best one. Individualize the arterial blood pressure targets. As I said, because there is a dissociation of macro and micro circulation, because the patient, if he has got a pre-existing hypertension, hypertension, blood pressure getting treated, and that one multiple drugs at that point of time, the things will be different. Then vasopressor induce an endogenous fluid recruitment and may limit the positive fluid balance. This is important. So that is why early use of vasopressin, as I said, then reassess the fluid status and cardiac output after the initiation of vasopressor. You have to see that volume status is adequate on all those patients where you are starting. Then if all these things are not working, then hydrocortisone should be added to the vasopressor to get the advantage of this drug. And it has been shown in surviving, it has been shown through various studies that a low dose of hydrocortisone is always beneficial in patients who are refractory to the inotropes and vasopressor. Then vasopressin in patients with right ventricular failure, because it causes pulmonary vasodilatation. Rather, that is why it has been shown to be useful. And there is no maximal dose of vasopressor. This is also an important point, because many times we see that in previous lecture we used to read that you should not go beyond this thing, beyond that thing. But nowadays we see that we have to remain flexible with the dosing of this drug. And as it was said previously, that enteral tube feeding should be stopped once we are using vasopressor. Now the concept has changed, and it says that enteral tube feeding can be initiated while the patient is under vasopressor. So these are the conclusive points from my side. So thank you very much for your quiet listening. If there is any question, I'm ready to answer.
Thank you very much, sir. You have done very nice job for this topic, and this is really blessing for us. We have learned so many things from your talk. Now I invite Dr. Jayaprakash. He's one of the moderator for this webinar. He's MBBS gold medal, DNB, FCCS, PhD has just studying. He is assistant professor, Department of Critical Care Medicine, RIMS, Ranchi. And now I invite Dr. Jayaprakash to look upon the chat box for question answer session.
Yeah. Sir, there are two questions in Dr. Asutosh Kumar Jha. He wants to know that what should be the vasopressor of choice for a patient of incomplete abortion having a chronic anemia, hemoglobin of 3 gram, BP 50/24, pulse 92, and when there is delayed availability of blood.
This is an extraordinary case where you can see there is a multi-organ involvement. Okay. Patient is anemic. Obviously, the heart must be very weak. So patient may develop a cardiac failure. I don't know whether the patient is in cardiac failure or not. But obviously, there is a component hypovolemia also. Hypovolemia is there, cardiogenic involvement is there, and probably because say ANC patient, we do not know whether the septic component is also there or not. So definitely, to start with, we have to look for adequate. First of all, we need these kind of patients need a very good monitoring. We need a very good monitor to manage these kind of patients. So if you have invasive good monitoring, then first of all, you replace with IV fluid and blood, and you assure the volume status. In the meantime, you have to see the kidney function also, because kidney is also an important thing. So for that, you need to improve the perfusion pressure. So always start with noradrenaline, and gradually with the requirement of the UC after volume replacement, blood replacement, what is happening, how the patient is responding, if there is a cardiac component there or not, anemia has been improved or not, volume correction has been properly taken care or not. And then, as I described in my slides, you can select the vasopressor. Obviously, they have to start with norepinephrine and then gradually switch to whatever requirement is there, depending upon the patient's profile after appropriate filling is done.
Asutosh sir, I feel that after looking at your case scenario, the patient of incomplete abortion there is hemorrhagic shock. So this is case of hypovolemic shock. So accordingly, you have to manage that. First, you and
anemia,
you
because anemia, you never know because they have not treated. Severe anemia might lead to cardiac dysfunction. So there may be requirement of dopamine, but we can't say at this point of time. That is why I say we need a very good monitoring. What is the cardiac status of this patient? Whether she has gone into failure or not. All those things have to be determined. So there is no straightforward answer to this kind of cases. Okay, next.
Dr. Vinita Panigrahi, ma'am, wants to know that the adrenaline, she has given that one scenario that if can we give adrenaline through endotracheal tube and it's any role in severe anaphylaxis?
Previously, we used to give 3 times actually. I think long back, more than 10-15 years back, it was described in the literature that you have to, if you are giving adrenaline through endotracheal route, you need to give the 3 times the dose which you give in through intravenous route. So we used to give 3 milligram of adrenaline through endotracheal tube to get the effect what we used, which will be called as an equivalence to the IV route. But nowadays, I don't see that there is any kind of recommendation of endotracheal adrenaline for resuscitation. You are mute.
Dr. Sanjeev Kumar. Yeah. So Sanjeev sir wants to know that differences between the enteral versus parenteral feeding in septic shock, which is better, and whether is combined enteral plus parenteral feeding good, having good options.
No, actually, when we are talking about shock, we don't talk about the overall critical care status of the patient. We only talk about whether feeding in parenteral is always open, but we talk only because of severe vasoconstriction. Many literatures say that because of severe vasoconstriction, there may be a disturbance as far as gastric absorption is also concerned, and patient may develop pulling of blood more towards the GI system, and that is why the coronary steel may develop, and the patient may go into again the myocardial oxygen demand may increase and the heart may get compromised. So those were the ideas. But clinical studies, because we are not of those kind of, we don't do physiological studies, but as far as clinical studies are concerned, obviously it was initially recommended that if the patient is on vasopressin, avoid enteral feeding. But nowadays, again, the concept is changing. Last couple of years, 1 or 2 randomized trials have come and they have suggested that even if the patient is in shock, you can start with the enteral feeding. There is no harm. So that recommendation is there now in ESPN guidelines. So that is why I have shown in one of my last slide that yes, it can be given.
So one question is from my side. When in ICU patients, when patients is having low ejection fraction, and that patient is having diarrhea, one-sided, he's facing cardiogenic shock, and another side is facing hypovolemic shock. So what is the role of lagging raise in that situation, so that we can judge whether this patient require fluid also or not?
No, first of all, you see, whatever shock it is, your volume status is very, very important, because all these drugs will only work if the volume status of the patient is adequate. So by raising the legs, what you are doing, almost 20 to 25% of the volume which is there in the lower limb, you are trying to push it to the central circulation, that is towards the heart. So what is happening is that once you start doing leg raising, it will increase the central volume of which is required at the level of heart. But on the other hand, if you see that the patient has got a continued diarrhea at that point of time, you need to fill the patient, even if he is suffering from some kind of cardiac ailment, even if he is in heart failure, a volume resuscitation of 500 to 1 liter has been said that it is not harmful. So you can give very safely up to 1 liter of fluid, and it is there in the surviving sepsis guideline also, that even in cases of who are having myocardial dysfunction or of those patients who have got some kind of cardiac problem, where we see that literature says that fluid restriction is required. But if that patient is in shock, at that point of time, you can give safely up to 1 liter of fluid. And that from that concept, actually, this fluid challenge concept of fluid challenge during shock was developed, and that is still practiced, and that is not yet out of the literature, and that says that you can give safely up to 1 liter.
Thank you, sir. I don't think there is another question in chat box.
Yeah, so I would like to invite our second speaker, Dr. Vinod Kumar Singh, sir. Sir, please continue. Please, yes, sir.
Dr. Vinod Kumar Singh is MD, MRCP, European Diploma in Intensive Care, FCCP, FRCP, Edinburgh, FICCP, and he's Senior Consultant, Department of Critical Care Medicine, Sir Gangaram Hospital, New Delhi. And he is also son of this soil. So I am proud of Dr. Vinod Kumar Singh, and I'm inviting him for his talk.
Thank you, sir. I'm just trying to share the slide.
Open your PPT, sir, and then put press share button.
Just a minute, I'm in the PPT. It's not getting shared, Dr. JP. Actually, I've opened it.
JP, sharing right मेरे पास था, इसको डॉक्टर विनोद को ट्रांसफर किए कि नहीं?
Sorry,
शेयरिंग राइट ट्रांसफर करना होता है ना, डॉक्टर विनोद को ट्रांसफर करना पड़ेगा ना?
हाँ, वो मैंने दिया है ना सर लिंक. Once he will open that and
the slide is open.
Yeah, okay. Anyone can share that because we are we all connected with the same link. Sir, आप share screen वो बंद कीजिएगा तो सर.
Okay,
Ah.
I'm just stopping the share screen.
No,
Now
no,
I
you
said,
yes. Now you open the PPT and from there you press that sir share button.
now I've opened the PPT
Okay.
and then I'm pressing the share button of the Zoom.
Yes.
Yeah, I've done it. It is somehow it is not opening, JP.
No, no, I am from here. I am getting that.
Mhm.
O- Open your PPT, sir.
Yeah, I've opened my PPT. And now I'm trying to share it, share screen. Okay,
Yeah.
I've done a share screen. And then my PPT is visible here. Okay, just a minute, JP. Now, is
Yes.
it visible now?
Yeah, yeah. It's coming now. And make it full screen, sir, now.
हाँ, अभी अच्छे से दिख रहे हैं.
Okay.
Yeah, done.
So thank you, Dr. JP and Dr. Anjan for inviting, and thanks to everybody for our audience and nice introductions. What I'm going to talk about is arrhythmia in ICU, and this is one of the most common problems we face in the ICU, and whether the patient has got a primary problem related to the heart or it is not related to the heart. Sometimes they present as acute crisis. Okay. This is a common problem in ICU and associated with sometime high mortality depending upon the type of arrhythmias. And also we see that the arrhythmia in ICU is slightly different from those who has got a structural heart disease and those who are getting admitted from some other regions. So the common factors are infection like sepsis and sepsis related problem, sometimes electrolyte abnormalities, medications also, ischemia, anemia, hypoxia, changes in the volume status of the patient and hemodynamics. So as a physician, as an intensivist, we should understand that there are so many non-cardiogenic factors for the arrhythmia, which we should know. And also, we should have some idea about the ECG, because ECG is, again, it is the core things to diagnose the arrhythmia and to stratify the arrhythmias also. So there are certain common arrhythmias we see in the ICU, like sinus tachycardia, atrial fibrillation, atrial flutter, and some conduction abnormality like heart block, that is could be first, second, or even the complete heart block. So these are the common arrhythmias in the ICU. But we also see some important, if you're not intervening immediately, they're probably going to not coming out from the arrhythmia and will make die. And these are two things, ventricular tachycardia and ventricular fibrillation. Why I have separated this? Because we should not miss, whether you're a physician, intensivist, cardiologist, you should not miss this type of arrhythmia, ventricular tachycardia, because they are the deadly one, which is important to understand. Then there are third category, which is interesting, and it is an academic exercise for intensivist physicians, like tachycardia, bradycardia syndromes, long QT syndromes, and VT storm. These are diagnosed at tertiary care hospitals, difficult to manage in the primary care setting. But if you have something for management or some management plan, they can be also taken. So we should have some idea about arrhythmias when we are doing in ICU. Now, how to approach to arrhythmia? There are certain things which is very, very important. If you are looking at the patient, you should look at the rate. What is the heart rate? What is the rhythm? Whether it is regular or whether it's irregular. The second is look at the PV, whether it is present or whether it is absent, upright or monomorphic. The third thing you should be looking at the QRS complex, and important to know whether it is a wide QRS complex or it is a narrow QRS complex. Also, you can see whether it is a monomorphic or polymorphic. We'll discuss later on. And then relation to the P wave with the QRS is very important, and that will also help you in diagnosing the arrhythmia. So these are the ECG findings. Also, clinically, you should be able to know that how it has got onset, whether it's the acute onset and gradually onset, and what was the response to the vagal maneuver. So if you combined all these clinical and ECG pictures, most of the time you will be able to have a diagnosis of arrhythmia. And if we look at the most common type of arrhythmia we see in ICU are most of the time the sinus tachycardia, which is not an arrhythmia. Just a minute, I'm just trying to minimize it. Sinus tachycardia, and it is diagnosed not very, very easily if the heart rate is more than 100 per minute. And P waves QRS morphology is normal, and it is a normal thing. It is a sinus tachycardia. The important thing is that we don't require to reduce the rate in cases of sinus tachycardia, because most of the time it is a compensatory sympathetic response. And if you try to reduce the rate of sinus tachycardia, heart rate in this situation, patient might have a dangerous hypotension, because the sympathetic drive, which is maintaining the blood pressure and the heart rate, and can lead to a severe hypotension in such patients. Most of the time, sinus tachycardia does not require any treatment, except certain situations, like if drug-induced tachycardia sometime, and also if the sinus tachycardia is inappropriate, like if the patient has got a severe anxiety and other things, that can be treated, but mostly it is not required to be treated. The two drugs we all know that can be used. One is the beta blocker and ivabradine, and it is your choice that what you are going. Most of the time now we have shifted from beta blocker to the ivabradine, and that both can be used. Oh, sorry, the slide is not moving. Okay, so now we'll see a case, a 28-year-old woman which is transferred from outside, a 32-week pregnant. She had a severe mitral stenosis and she was in heart failure, class 3 NIH symptoms. She arrived in the hospital, and after arrival, you do AECG, you found that the patient has got atrial fibrillation. She's dyspneic, and because of the desaturation and dyspnea, she got intubated, and the blood pressure fell down from 70 MAP to 50 MAP. Okay? And this is the ECG. And if you look at the ECG, you can see that the rhythm is irregularly irregular. If you look here, and the QRS morphology and the rhythm is totally irregular. And if you also see that there is no P waves and the ventricular rates are variable. So what we can see, what is the ECG diagnosis is a narrow complex irregular tachycardia with no P waves. And if sometime you can see a fibrillation waves. So if you make this diagnosis is a narrow complex irregular tachycardia, then you are making a diagnosis of atrial fibrillation. This is probably the most common rhythm disturbance, but the important thing is that Somebody tolerates very well and somebody will not tolerate depending upon the hemodynamic status of the patient. And treatment is also straightforward. We have to think whether to go for a rate control or whether to go for a rhythm control. Now the question arises in intensive care unit if the patient has got admitted and you are not aware about when the AF got onset, and if it is more than 48 hours or less than 48 hours, then probably it is time to go for a rate control, and you can use a beta blocker, you can use a calcium channel blocker. Mostly for all practical purposes in ICU, we are using amiodarone or cordron for AF patients because of several benefits, because cordron can control the rate and rhythm both. And also it has got a very, very few impact on the, or less impact on the hemodynamic status of the patient. Except in certain situations, like if the patient has got a history of pre-excitation, if the patient has got a pregnancy and breastfeeding, because amiodarone again is not good for the fetus. If the patient has got a AV block and has a significant bradycardia and long QT. Okay, the question of long QT is very difficult to determine because the patient has gone to the atrial fibrillation, has come to you. So these all factors, if you have a pre-existing history, then only you can decide. Otherwise, it is advisable to use amiodarone and cordron in such patients. Now, similar situations, if you look at this ECG, and again, this is a narrow complex tachycardia, if you look at here, but the ventricular rate or QRS complex is coming at the regular interval. And also you can see a sawtooth pattern, the multiple P waves. And after 2 or P waves, there is a block or there is a ventricular rate. So rate of the ventricle and rate of the atrium is different. So if this type of ECG, you can call it is a regular tachycardia, but with a block, it is a 2:1 block or 3:1 block or 4:1 block, depends upon, and that determines the heart rate. So if this is the ECG, this is probably the patient has got atrial flutter. Now, from the treatment point of view in intensive care unit and even in the acute care medicine, there is no much difference in the treatment of atrial flutter and atrial fibrillation. Both has got the same risk of thrombosis, both has got the same risk of chronicity, and both has got the same response to the treatment also. Okay, so if you find flutter, if you find fibrillation, again, you can try to have the same medication and same treatment as atrial fibrillation in such case. In fact, if you try to control the heart rate in these situations, it will be difficult in case if you got a 2:1 block, and sometimes very difficult to manage, even more tougher than the atrial fibrillation. Now, if you look at this ECG, this is again a narrow complex tachycardia, very, very common in intensive care patients due to many reasons. And if you look at this, this is a AV nodal reentrant tachycardia. But from the diagnosis point of view, we can say that if you try to understand this, it is a tachycardia, a narrow complex regular tachycardia, and there is no P wave. Look at here. Sometime the P wave may be coming after the QRS complex, or maybe sometime before QRS complex, but most of the time it is not visible. Not only this type of tachycardia, and it is contrary to our belief, is that most of the time associated with palpitation and also syncopal attack. And also, this is the tachycardia which is sudden in onset. So if these features are present, we should make a diagnosis of a supraventricular or AV NRT or atrioventricular nodal reentrant tachycardia. Because the treatment is slightly different in such situation than AF and other things, so the treatment of choice is, we all know that if you have a narrow complex regular tachycardia, we should go for a vagal maneuver. If it's not responding, go for adenosine. If the patient is hemodynamically unstable, then go for synchronized cardioversion, and maybe sometimes requires catheter ablation. If we look at here how it responds to adenosine, you can see that we all know that adenosine is a very good blocker of the AV node. So sometimes the patient can go to asystole also, but most of the time there will be a bradycardia, some irregular rhythm followed by a sinus rhythm in adenosine. And there is chances of recurrence is quite high if it is a diagnostic that the patient has got a supraventricular tachycardia. Now we'll come to the other type of narrow complex tachycardia. We call it multifocal tachycardia, which is also seen in ICU. And because to diagnose it, we have to look at the P wave. And if you find that there are three distinctive P wave, we can call it multifocal atrial tachycardia. And the causes are quite distinctive. If you have a pulmonary embolism, RA-RV dilatation, increased sympathetic drive, hypoxia, hypercarbia, beta-2 agonist, theophylline, electrolytes abnormality, and secondary to diuretics. So we have seen this type of tachycardia when the theophylline was the treatment for acute severe asthma. And we have seen patients dying due to tachycardia because asthma, acute severe asthma, is one condition where there is a very, very high sympathetic drive. And if this patient lands in slight degree of hypoxia, and if you have given theophylline, they are bound to have multifocal atrial tachycardia and difficult to control such type of situations. So be very, very careful in managing and giving theophylline. Most of the time, we are not giving nowadays theophylline. So again, you can see here, look at the arrows, how the P wave morphology is changing. So if this is the situation, this is multifocal. Why we try to differentiate multifocal tachycardia from a paroxysmal supraventricular tachycardia? Because of the response. Because this multifocal tachycardia need to control the etiology besides giving the antiarrhythmic drug, and they are very, very difficult to treat type of tachycardia. Now come to the second case, a patient of 78-year-old man admitted with post-CABG, and day one he was treated for atrial fibrillation with amiodarone, and day 3 patient has got hypoxia, delirium. He was given salbutamol, nebulizer, diuretic, and haloperidol. And then you get a call that the patient has become unconscious. And this is the ECG. We know that if this type of ECG is present given this situation, then there is a very distinctive form of ventricular tachycardia, and we call it a polymorphic tachycardia, where we also call it torsades pointes, where you find that there is a gradual change in the amplitude and there is a twisting of the QRS complex. This is again a wide complex tachycardia. So we are coming from narrow complex tachycardia towards the wide complex tachycardia, and this is very distinct type of tachycardia. That's why I have taken. See, there you find there is always a risk factor for tachycardia, and here you can see that the patient has got a salbutamol nebulization, patient has got amiodarone. All this can cause a prolonged QT, and haloperidol again prolonged QT. So these type of things you must look out in the history when you find such type of ECG. So here the potential, here the only thing which is not a potential contributor is hypermagnesemia, because we all know that magnesium is the treatment for such type of patient. So hypokalemia, salbutamol, prolonged QT due to haloperidol or RNT phenomena because of the temporary epicardial pacing in post CABG patient. This is the risk factor for patient of polymorphic tachycardia. So the question is, in the literature, if you see in the books, the prolonged QT must be present. But as you know, practically that once VT is there, you cannot measure the QT. So once you settle the VT, then you should be able to measure the QT interval. Or if you have a previous ECG, then you can find out that whether the QT was prolonged or not. And the other risk factor, hypokalemia, and some drugs which can cause it. Hypomagnesemia is the most important cause. And treatment is, we have to see, and we have to actually stratify the risk. If the patient has got a hemodynamic compromise, do a defibrillation and go for ACLS. If you find that the patient has got a perfusion rhythm, go for the magnesium. Now come to the another case, a 66-year-old man admitted with pneumonia. I have got ejection fraction of 30%, post a CABG done in the last 3-4 years, and the patient has got a sudden onset of unconsciousness. So again, you are looking at the ECG and you find that this is the ECG, and we all know that this is a regular broad complex tachycardia. The previous one was a irregular tachycardia or polymorphic tachycardia, which was also a broad complex, but here it is a regular broad complex tachycardia. If you find that there is a uniform QRS complex and in the each lead, if you see here, and if you look at the QRS complex is more than 160 millisecond, AV dissociation, capture bits, fusion bits, and also there is no any RBB and LVB morphology. Okay. The important thing I want to emphasize is that there can be a many differential diagnoses for the broad complex or broad QRS tachycardia, which I have mentioned here, which can be a ventricular tachycardia, which could be a supraventricular tachycardia with a aberrant conduction. That could be a WPW, that could be a bizarre baseline QRS, that could be antigrid or his Purkinje system problem. The third is that if you have a ventricular pacing, you will have a wide complex tachycardia. And fourth is sometimes ECG artifact. So there are so many factors which can cause a broad complex tachycardia. But important thing for relaxation of the intensivist and the physician is that if you have a broad complex tachycardia, which is a regular tachycardia, you should presume VT, ventricular tachycardia, unless proved otherwise. That means 90% of the time. If a regular wide complex tachycardia is ventricular tachycardia, and you have to manage the patient according to the protocol of the ventricular tachycardia. There could be a different cause also for academic discussion, but managing with for the ventricular tachycardia is not a bad thing or not a wrong practice in such situation. And we all know that the ventricular tachycardia management depends upon whether the patient has got a pulse or patient has got no pulse. If the patient is pulseless, we have to go for ACLS protocol defibrillation. And if the patient has got a pulse, the management principle changes. We'll discuss it. So if you look at a patient who has got a tachycardia in ICU or in the emergency, you should have a patient and then you should go for a wide complex tachycardia artifact, pace rhythm, or SVT with a aberrant conduction. If you have excluded, then the diagnosis remains ventricular tachycardia, and then you should have to look at it is a regular monomorphic ventricular tachycardia or it is a polymorphic. If a polymorphic with normal QT, okay, fine, prolonged QT, it is a torsitive hypotension. If a monomorphic idiopathic or a structural heart disease, and then it is a low ejection fraction or it is a normal ejection fraction. So this is how we try to stratify the classification of tachycardia and management of tachycardia. But remember, most of the time, this for evaluation of such type of different tachycardia, if the patient is having pulse and perfusion rhythm. If the patient is pulseless or the patient is hypotensive, probably you don't have those time or to analyze the ECG in such a way. So if a patient has got an adult patient who has got a tachycardia and the initial is supply the oxygen, IV access, do a ABG, and try to identify the reversible cause and treat. The second step is you try to find out whether it is a life-threatening, if the patient has got a shock, syncope, myocardial ischemia, or severe heart failure. If the question answer is yes, then you should go for a cardioversion. And you should go for a synchronized cardioversion. You give a sedation. If the unsuccessful, give amiodarone 300 milligram over 20 to 20 minutes, and then you go for a synchronized DC cardioversion in such situation. So this is straightforward in cases where the patient has got a pulseless tachycardia or the patient has got a tachycardia with a hemodynamic compromise. The situation arises when the patient has got a tachycardia and the QRS complex is broad or narrow. So this is a combined effect. If the patient has got a broad QRS complex tachycardia, then you have a two type of possibility. One is that if it is irregular, then it could be a aberrant conduction with atrial fibrillation, and could be a polymorphic VT also. If a regular, then it has to be a ventricular tachycardia of uncertain rhythm. And if you have a narrow complex tachycardia, then you have a regular or irregular. Irregular narrow complex tachycardia, only atrial fibrillation is the one of the diagnoses. If the patient has got a regular, then the most important diagnosis remains the paroxysmal supraventricular tachycardia. And here we have to give the adenosine. So if you have a tachycardia, if it is a patient is hemodynamic compromised, whether it is a broad complex, whether it is a narrow complex, you have to go for a DC cardioversion. If the patient is stable and rhythm is perfusing, then the treatment for broad complex QRS complex tachycardia with irregular tachycardia, again, you have to go for polymorphic VT, magnesium 2 gram for over 10 minutes. And if you have atrial fibrillation and a narrow complex tachycardia, irregular tachycardia, cordon is the choice, amiodarone is the choice. Regular broad complex tachycardia, again, cordon is the drug of choice if the rhythm is perfusion. And if there is a SVT and you find that there is associated bundle branch block and other things, then accordingly we have to manage it. Most of the time it is cordon. Narrow complex tachycardia, regular, irregular. Regular is that mostly it is supraventricular, and the treatment is, we all know that adenosine 6 milligram, not responding 12 milligram. Before that, you can go for a vagal maneuver, whether the patient is responding or not. If it is ineffective, verapamil is the drug of choice, or you can go for a beta blocker. Okay. If all the things is regular broad complex or even the regular narrow complex is not responding, again, the synchronized cardioversion is required in such situations. Irregular tachycardia, again, we have to go for rate control or rhythm control because of the atrial fibrillation. So it is a very, very simplified algorithm, and it is basically a rhythm of European Resuscitation Council, which most of the, and AHA also has the same same algorithm. So, so now we come to the bradycardia, low heart rate. It could be a sinus bradycardia, could be a first degree heart block, AV block, could be a second degree AV block type 1, second degree AV block type 2, and third degree AV block. So look at here. If you look at here, you can find that the patient has got a bradycardia, and this is a sinus bradycardia because QRS complex and morphology no change. And this bradycardia, unless and until the patient has got a hypotension or some type of hemodynamic compromise, no treatment is required for sinus bradycardia. Okay. Now, if you look at this ECG rhythm, typically the PR interval is RR interval constant, but PR interval is prolonged. It is not changing with the rhythm strip. So this is a first degree heart block. We all know that. Like the only thing is QRS complex is normal, Q anterior relation is normal, QRS anterior relation, and PR interval is prolonged, then it is a first degree heart block. Nothing is required for the first degree heart block. We have to treat the primary cause. Maybe patient has got a some type of cardiovascular problem, ischemia that can lead to first degree heart block. So we have to concentrate on the primary treatment for the primary cause in such situation. The second situation arises if you look at here in the upper one and lower one ECG. The upper one ECG, if you look at the RR interval is variable and there is a variable prolongation of the PR interval. And after some prolongation, there is a drop bit. And this is typical of the, you can say that type 1 Mobis block, and the second when the QRS complex is widened and the PR interval is constant, it is a type 2 Mobis or secondary heart block. The important thing is that in the intensive care unit and is both are, whether it is a type 1 and type 2, very prone and risk factor for complete heart block. So patients who are going for a surgery in the GA and maybe sedation and anesthesia, they are very high. They are prone for complete heart block. And we all know that once the patient goes for complete heart block, there is a hypertension and causes and low perfusion. So these patients should be taken care either by prophylactic pacing or should be some medications which should prevent the complete heart block, sympathetic mimetic drug. Most of the time, good observation for the Mobis type 1 block and prophylactic pacing for the Mobis type 2 block. Now look at here. What is happening here? If you look at here, again, the RR interval is getting constant. The PP interval is also constant. But the problem is that the PR interval is varying and there is a dissociation. The P wave has got its own rate and the R wave has got its own rate. This is, if you find that such type of ECG where there is a atrioventricular dissociation, maybe with narrow complex, maybe with wide complex, this is a complete heart block. And if the patient has gone to complete heart block, mostly these patients are symptomatic and we need to intervene in such type of patient. And we'll come to know that patient who has got an adult bradycardia and we should go for a ABCD approach, give the oxygen, appropriate IV access, ECG monitoring, and identify and treat the reversible cause like hyperkalemia, like sometimes hypermagnesemia also can cause such type of. And then you stratify whether the patient has got any of the life-threatening event like shocks in coke, myocardial ischemia, and heart failure. If you find that the patient has got a this type of high risk factor, and you answer yes, then you should go for a atropine, 500 microgram IV stat, and then you find that the patient's heart rate has improved or not. If it is not improved, then you should repeat the atropine and you can give a maximum of 3 milligram. You can also give a isoprenaline infusion, 5 microgram per minute IV. You can give adrenaline. And also you should, if you have a transcutaneous pacing, you can go. And finally, you have to take a help for the cardiologist to go for an intravenous pacing. If there is a persistent bradycardia and low perfusion, then the temporary pacing is the answer in such situation. Now, if these signs are not there, then you should go for observation and you should, if the patient has got a recent history of asystole Mobis type 2, as we have discussed that, and a complete heart block with a broad QRS complex, and if the patient has got a ventricular pause, all these situations should be treated like a heart bradycardia with a hemodynamic compromise. If you look at here, if these are not the situation, then you should observe such type of patient. So we can see that a bradycardia patient, most of the time, if there is no hemodynamic compromise, observation, Now, if there is a risk factor for asystole, then treat is like a hemodynamic compromise. And the treatment of patient with hemodynamic compromise is atropine, repeat atropine, go for isoprenaline, go for infusion adrenaline, and if no, then transcutaneous pacing, and think for or plan for a transvenous pacing. So, according to the advanced cardiac life support, we can divide arrhythmia, which requires a shockable. That means the initial treatment is DC shock, and this is the ventricular fibrillation and pulseless VT. Those who requires a no shock but cardiac massage is the pulseless electrical activity and asystole. So any patient who is unconscious, we should differentiate the ECG based on these things. And again, tachycardia, you could have a wide complex tachycardia, you could have a narrow complex tachycardia, a bradycardia, which is sinus bradycardia with various type of AV blocks. Some are completely asymptomatic and some are completely symptomatic. And the management should be stratified according to the hemodynamic status of the patients. So thank you very much for your patience.
Thank you, sir. Thank you. Very
Yes, sir.
excellent talk. Actually,
Thank you, sir.
case-wise discussion was very nice.
Yeah. If
So,
any question is there?
Dr. JP, just unmute yourself. Yeah,
Yeah. Okay.
and just see the chat box.
Actually, it was very elaborative, so I feel that there is no question. Only nice talk of Vinod sir. Dr. Sanjeev Kumar said, yeah, he's from IGI, and I feel that he's very close to Vinod sir.
Yeah.
He has written
is
almost
good
all
that the
has been
Sanjeev is
covered.
also-
So, no question. So, yeah, please, Raju, yeah, please conclude the session.
Yes, this is very nice to hold as a host first ICCM meeting at Chhapra. And I'm very much thankful to Dr. JP, Dr. PK Bhattacharya sir, and Dr. Vinod Kumar Singh sir. I really very much enthusiastic to conduct this meeting. We are really got so many things from these talks. And again, I am very much thankful to both of our learned speakers and Dr. JP also for his throughout communication and facilitation for successful program. Thank you so much, sir.
Yeah.
Thank you.
Sir, one question, just I have seen in chat box that Dr. Murthy want to know that how to treat intraoperative SVT.
Yeah. JP, the treatment is of intraoperative APT and Dr. Murthy is not different from the patient who is in the ICU. And again, you have to stratify whether the patient has got a hemodynamic compromise or not compromise. If the patient has got a hemodynamic compromise, you should directly go for a synchronized cardioversion with 100 to 200 joules. If the patient has got a no hemodynamic compromise and patient is perfusion rhythm, then you go for adenosine followed by a calcium channel blocker. There's no difference in that.
Thank you, sir. Thank you.
Okay. So thanks to everybody and a special thanks to Dr. Rajiv and JP and everybody. Dr. Sanjeev, very nice to see you.
Thank you from my side, and it's
Yeah,
very
yeah.
good thing that from our zone, Chhapra branch has also started
Yes,
the
that is started.
academic activity. It is a very good thing. Thank you, Rajiv sir, for your kind contribution for the starting such type of the thing.
Welcome, Dr. JP sir. Dr. Sanjeev.
Thank you, sir. It's good to see you, sir.
And
Okay, so good night to everybody.
Good night.
yeah, good night.
Thanks to JP and Dr. Rajeev sir. And that's it.
Thank you. Thank you,
sir.
Yes,
We'll meet again.
Bhattacharya sir left.
Okay.
Thank you.
Okay, thank you.
Thank you.
Thank you. Thank you.
Good night to everyone.
Good night.